what we're then doing is presenting those to the clinician in a ranked order, effectively. So, what would be the most relevant trial match for that particular patient, the second best, the third best, the fourth best. But it's not a lossy process. What we're talking about here is, the way I describe it is true clinical decision support. So we're not suggesting this is the perfect match for this patient. We're showing all of the trials, but ranked based on what the engine is suggesting would be relevant for that patient. So things like if there's a biomarker present, for example, and a given trial is targeting that specific biomarker, then that's given a higher weighting. So you'd probably see that higher up the ranking. We also facilitate a number of different workflows. So one would be what we call point of care, which is really focused on the oncologist and patient focused. And then the other side is more research focused. So what you typically get in a CTU, where you're looking at the trials and what patients are coming in for those particular trials themselves. We talked earlier about a number of different windows and systems that clinicians need to open up to use. And whilst we're constrained somewhat compared to our American colleagues, just in terms of versions of FHIR, for example, in some of the bigger EPR systems like Epic, we are embedded into that app orchard within Epic. So in fact, you could use the system within your EPR, assuming you have that, or indeed separately. Can I have the next slide, please? Thank you. So this is really what the workflow is. It's quite straightforward and happens automatically. And the intention here is, Helen touched on it before as well, is making it just incredibly easy to bring clinical trials into the conversation with the patient without the clinician really having to do any additional work. Because what we understand is through the work that we've done both over here and actually in the US, and the same problems exist, in that nationally it's incredibly challenging to keep up to date with what trials are being run and where. And it's great if you've got a network of people you can phone up and talk to, but outside of that, it's incredibly time consuming and challenging to do. So by doing this, we're putting everything in relation to clinical trials in front of the clinician automatically without any additional work having to be done to do that. And the great thing is the way we deliver this is really what, in SaaS, so software as a service. So the intention is that actually you can use this at any point within the trust. So you might want to use this in outpatient clinic, but equally you'd want to use this probably at NDT. And actually you can use this more and more remotely. Wherever we've got the data and we can access it, then that works really well for us. Next slide, please. So I think it's a good point to talk about, and I appreciate that was a really, really fast overview of what it is we're doing. But I think it's also important to talk about what we're actually doing, in terms of putting this forward. So the intention, and I've got to say, take this moment to just thank, Michael for listening to me about a year ago, and putting in touch with Helen. And Helen's just been absolutely fantastic, and Tarek in helping drive this forward, and then also obviously the team at Bristol, and Adam clearly being here as well. So I know Adam's been really helpful in trying to help us overcome some of the challenges that we've had, and they're no different, I think, than what anyone else has raised here. But we've done a lot of work already, I think is the point to make. We've spent a lot of time with the clinical teams, with clinicians, mapping out those workflows. This is part of it. It's as clinicians, you're doing this day in, day out, so it's all in your head. You know what you're doing, but actually when you're looking to try and take a systematic approach to something, suddenly when you have to map it out, you sort of start to realize how many system integrations there are, how many different systems are talking to each other. So we've done a huge amount of that work. The environment is there and ready to go. But I think it's fair to say, we've had our challenges along that way too, and we're not there yet, for sure. Helen, I don't know whether you want me to carry on in that sense, or I don't know whether you wanted to ask me a couple of questions. I might be a bit more challenging now, given the virtual nature.
Yeah, thanks, Phil. You're really yeah, we were going to have a bit more of a conversation, but I don't know how we're doing for time, but maybe I'd just say to Phil, as a commercial company, working with the NHS, what would be your top 3 messages for us as an organisation who do really want to deliver for our patients and want to build our reputation for doing things differently?
Okay, so I think first and foremost for me, and I was doing this with Inspirata now, but I've worked with the NHS in this sort of role for 10 years. And it's where, for me, where I've had success and where organisations I've worked for have had success with the NHS, it's always been about finding the right people and the people who are going to work with you and champion, what we're all trying to achieve. Because we as commercial organisations, I always think of it as imagine there's a giant beach ball in effect, where we as a commercial organisation are on one side of that and we can see part of it, but we can't see the whole, the whole ball in essence. So things like, who do we need to talk to? Who do we need to connect with? We're happy to do the work, but often it's actually not even knowing who the right people to talk to are. So I think finding the right people who can drive the innovation, because the technology, it's a bit flippant, but I think the technology is actually the easy part. It's the people. It's getting those people involved, and then the resourcing's the real challenge. And I know it's been touched on before, is the IT side of things, and it's about trying to find creative ways of resolving that. I mean, to be honest, the technology is part of that. One of the beauties of natural language processing is that actually the ask that we have, for an IT department isn't huge, because we don't need them to really do anything to the data that they've already got. What we're really asking for is just access to it, because it doesn't need to be any given format. We can use the technology to do that. So that's part of what will help. And that's where, where I said earlier, we should think of artificial intelligence about numerous different technologies, and not necessarily that you have to get to a point before you can start considering it. Actually, certain AI technologies can help you wherever you're at. But it doesn't need to be done for that sake. So that's 2. The third one, I think, would probably be pick and choose the commercial companies that you do decide to work with. I've had experience of big corporate businesses and small, scrappy type startup organizations. But I think what's always been the case is that we as commercial organizations absolutely understand that we have to prove what our technology can do, and we have to provide value, because we work in an environment and in a system that doesn't have reams and reams of money to throw at technology. We aren't the US in that sense. We have to be demonstrating that what we are doing is solving a problem, and solving a problem that and delivering value in doing that. And I think by choosing the right organizations to work with, that's probably the best way to do it. And I think there's probably a happy medium in terms of the building it from scratch approach versus partnering with organizations to deliver.
No, thanks, Phil. And I'll get Michael back in. Mark has reassured me he is there. I was just going to say, hopefully next year we'll be able to present what has worked really well and what other learnings we can share with it. And it's been good fun so far. So I really hope that we can deliver over the next 6 months.
Thank you very much, Helen and Phil. And I'm sure both of you'd be happy to take questions either from the floor there, if there's anybody. Obviously, I can't see that, so Helen, you'd be able to notice that. Or if anybody else who's also attending virtually just wants to put the hand up, just allow a minute, because we were 5 minutes late starting. But Helen, anybody in the room that wants to ask a question? If not.
No, we can hear, thank you.
Okay, so if there's no questions, I'd say thank you very much to both of you. I can't wait to see the massive increase in patients going into all forms of trials, which is what we really want to achieve from this.
Good afternoon, everyone. I'll just a great success for the event so far. Mark, Tiago, Helen. That's excellent. Sorry if I forgot anyone from the organizer, but I hope you enjoy being here in our Park Campus. That's Park Campus in summer, so you will come to join us. I'm going to talk about the initiative. Last year, during the pandemic, I met Mark the first time and said, okay, let's establish a link with the local NHS trust. And and when I talked to Mark, the first meeting, I thought he's a computer scientist. Next time when I talked to him, I started to ask him about question. He said, I am a medic doctor, not some computer scientist. I thought, all right. So that is really help us to establish the first collaboration, and we are proposing to have Informatic Hub. So that is going to be my layout. Talk about the team within the university, and mention the other the course we established, a master in health tech, and then we're going to talk about a certain project we did within the university, so it gives you an idea what we have. That's the first team we have. It's Zainab and Kublai. They are working in within the hospitals. Zainab is a PhD student and a colleague. Kublai is a senior lecturer, course leader, and they are working with the hospital with the deep learning prediction model in lung cancer as well. So that is one of the research team. The other one is Tiago. You have met him. He's our he's going to be the course leader for the health tech, and he already the course leader for the computing as well, working in the deep learning diagnosis and early cancer detection, and also working with the development information system to support NHS process. And for future potential project, we are talking about data analytics and machine learning as well. So that is Tiago. We have Hassan. He's associate professor working with the ECG and EEG signals, and to create randomness to be used for the cybersecurity. And also there are potential projects from Hassan to talk about the psychological signals and reading the medical purpose, reading the quality of the signals, and AI algorithm as well. We have some previous project. I did mention that to you, Andrea. We have a patient safety system. We did that back. We reached to the point that we may make it happen within the hospital. That's the patient, they can answer 10 questions every day to measure their safety. So we have this capacity as well. There was another project we did about the dermatologist. That's because the referring system now, it's really long wait, and it's the same issue we talk about now. That's been reduced, the waiting to a massive to 50%, and we are happy to discuss that as well. Just try to show you what we have. We have this as well as a knowledge transfer project about diagnosis the mild cognitive impairments using the online tools to help people to prevent that cognitive decline as well. I would like to mention that it's about the hype cycle of the top 50 in the digital trend, and I'm interested in the green one because that's something it could be implemented soon. So, for example, it's been mentioned that NLP, AI, it's one of the chatbot as well. It's a topic we can walk in, and also the deep learning as well. I'm gonna not going to talk about that a lot because that's something outside of our topic, but I'm interested in some of these topics we can work together. Now, so the health technology, that's something we would like to discuss together. And as an outcome out of that, we have discussed the diagnosis, the treatment, monitoring, protect people from any cyber threats, also to improve the quality of life of many peoples. And then what I would like also to highlight, these are the topics we can discuss. Some of them being discussed, mentioned this in depth this morning, this afternoon as well. But also as a university, we are keen to work in this area. And I had a meeting yesterday with the Vice Chancellor to mention this event, and he said just to pass my greeting to all colleagues from the NHS, and we are keen to work with you in the different channels in this area. And also we have established, as I mentioned, Master by Research, MRES for health tech. It's going to start in September, and I talked to colleagues now, and especially Paul, about kind of channel which we can develop innovation by having a certain problem for 12 months for people, and they can do the recommendation or implementation, and they can have that. It could be part-time, it could be full-time. That's something we are keen to do it. And we did it by research because we feel that health tech people, this topic, it could be the kind of people we are going to get or getting. They are mature enough, they know what they are looking for, but they need the opportunity to do that work. They don't need to be taught. However, there are some courses in data science we can give them, but it's not part of their degree. The other thing is we can have a health informatic, health data science, healthcare science. That is being suggested yesterday by the Vice Chancellor, and he said, okay, we can have a taught master if they are. We are working with the NHS with a funded project, applied research as well, CPT courses as well. It's something we can do with the university. So that is Tiago. He's my colleague. He's the course leader for that. He has developed that alongside Mark, and we are going to start this course September 2022. And as I mentioned, it just try to bridging the gap in any area related to health tech, and having someone to handle a topic for 12 months to complete their projects and get their degree. And we are not going to stop on that. That's going to be the concept, and then we can take it further for applying for a fund and make it available to commercialize it. As well, it's as I mentioned, it's a project-oriented course. The student or the researcher, they are going to work in a real problem. So we are keen to propose any problem you have, so we can propose it to our student, and then we can make the link. We don't mind that to have a co-supervision as well. That's what we are trying to do, because a academic supervisor and someone from the trust, that's going to give a great experience to the students, and also it's a great channel we can communicate and take it further. The forward thinking, it's also something that we discussed within the department, is the computational pathology and AI. And that's something, it's a definition about, we talk about the complete probabilistic treatment for the clinical workflows. And that is something we are keen on it. That's the, whatever we discussed, is we can take it further through that. This is similar, I've seen one of colleagues, I think Andrea did that, said that the machine learning flow. That's the very simple workflow about how we actually we have historical data, train them, validate them, and then we have develop a model to do that. And in terms of I like the statistic of having the AI taking over the jobs. That's a myth. It's not going to happen. I'm telling you. So don't be scared. This is just a schematic diagram about what does it mean, a relationship between AI, machine learning, and we are talking about deep learning now. And that in the computational pathology, we are going to use the deep learning. And these are the deep learning segmentation, detection, classification, all these combined together to have high orders task by grading and predicted or detected or detect the tumor, for example. And that's parameters about what kind of what does it mean by computational pathology. Is actually something above the digital pathology by scanning or having only the EHR. it's the cream, and combining AI with that, it needs actually your experience before our experience. That's going to help you. We talk about terabyte of data, but as a human, we can handle it, but we have to combine both experience and they get the both of best of the both world. This is an example. You are much familiar than us with these kind of pictures, but the size we are in. So we have, for example, one slide could have equal to one library of CFR images of 60,000. That is really massive, hungry kind of size. Computer vision compared to the computational pathology. In the past, we do have people, doctors annotate on the slices, and then present we do have some automated, but actually in the future we are combining the AI to make a decision accordingly, and that is actually what we are intend to do, and we can work together to do that through our student. If I can show you that this is the human tasks and that's the machine task. When we talk about computational pathology, it needs a hard time and experience from human, and also hard machine learning algorithms. It's not something easy to and it has to be dedicated for certain application. It's not open to any kind of sectors. So now we talk about how can we do that? It's training more effective system required. We need labeled data, and that is your experience to be entered to the model. And obtaining that annotation, it has to be something from you, and that's the hard part. And then also, as I mentioned, the data set exists for machine learning algorithm. We have to have development and evaluation stage as well. That's our side. We can do it. Crowdsourcing, that's another topic. We can, like the app you did, it could be available for people, and then we can have a crowdsourcing to get what we call it, the annotated data set for computational pathology. And that's really a massive hand annotation. We need to improve computational pathology tools accordingly. So then we have the deep learning in order to identify really make the most of the slices we have, which is something we cannot, the doctor that cannot see it, the machine can help, not take over, help to make the decision faster and at the right time. How can we work together? We are suggesting to establish hub, health tech hub, which is academia, private sector, of course, the NHS. And these are the people who can join in that in certain projects. And we already start our idea to have an MRes by health tech, for health tech master by research. That's the starting point. We are going to move forward, having more placement student, having PhD student as well. The most important part is to get the real problem from the trust and handle it to the right hand within a certain time frame in order to have an active, in order to have a productive project. I think I'm on time. Thank you very much. And if you have any question. Thank you very much.
So thank you very much, Ali. I presume that you'd be very happy for people to approach you if they want to explore any of the things that you have highlighted there. It sounds like if you haven't already got good links with colleagues in pathology, that would be something that's worth considering, making sure that you get those connections.
Thank you very much indeed for inviting me to come and speak this afternoon. I'm Joanna Dundo, National Clinic and Informatics Lead Public at Digital Health and Care Wales. And I'm going to tell you a little bit about the SharePoint site that I've developed called IRENE. and a little bit about the organisation as well. I don't know how much you know about Digital Health and Care Wales, but we're a special health authority in Wales, which was established in April last year, replacing the NHS Wales Informatic Service. We are part of the NHS Wales family, and that includes 7 health boards, 3 trusts, and now 2 special health authorities. And our aim really is to take forward the next generation of services needed to transform health and care delivery. And these areas include frontline staff with modern systems. So we have over 100 systems that we build, maintain, procure, and develop within DHCW. And one of the big projects I'm involved in at the moment is for digital services for the patients and the public, where we're dragonising the NHS app for Wales, calling it the NHS Wales app. And my role there is as engagement lead for the programme, mainly from a patient perspective, but also involved in other things as well. We also have other systems developing as well. We also use data to provide insight and improve how health and care services are delivered and accessed by patients. So this morning, all the conversations and the debate has been really interesting from our perspective. And we've got Wendy and Kaylee here as well, who work from the Welsh Institute for Digital Innovation Information. So we work very closely with them as well, and the SAIL data bank. We're also, as I said, helping Welsh people manage their own health and recovery from illness by putting health services in their pocket. We also now have a dedicated national cyber resilient unit based within DHCW, and also developed the digital standards to allow faster development and delivery of digital services, including our national data resource. And I noticed that you were talking about fire earlier. That's one of the areas that we're doing a lot of work on, and open air as well. And as all of that, we're looking at protecting the valuable data assets by modernising data storage and adopting a cloud-first policy. So why is innovation in digital health and care Wales? So, as I said, DHCW has a key role to play in innovation and creation of digital services. We have a very talented workforce. However, due to complexity and fast-moving nature of innovation, our services and systems, we originally thought it was difficult to spend time thinking and managing innovation and promoting our ideas. We want to share ideas, knowledge, expertise and experience across NHS Wales, and staff to enjoy getting involved and being creative. So one of the things I've developed a few years back was some fact-finding about the organisation. Our predecessor organisation was a Bevan Commission Technology Innovation Hub. Bevan Commission is an arm's length organisation in Wales, which provides funding for innovative projects for clinicians to work with industry partners. And a lot of the time, as you can imagine, the request to DHCW to support innovation or access to data and information is also often thought as an afterthought. There was a lack of awareness locally and from other national organisations of the national agenda, which is now changing because we are a special health authority. And there were lots of ways of innovative ideas that come into the organisation. There was general confusion about accountability, testing, business as usual, etc. And these are just some of the impacts that we have. We probably still have things as well from a local and a national perspective, whether things are short term, there's a lot of pilotitis, I would call it, that happen for a couple of months, and then whether the projects will last for 3 years or longer because of the contracts that we have. We also have the health boards and trusts developing digital standing operating plans, and we also have a 3-year plans, which we call the integrated medium-term plans and business plans. As you can imagine, we have a lot of plans and strategies, and a lot of that also impacts. If it's not on the IMTP, then we can't put that into our pipeline. So that's one of the things we're looking at. The teams are also very busy as well. So we decided that we'd set up something called a dynamic purchasing system, very similar to G-Cloud, which is where we get a list of all the suppliers that like to be part of what we're doing, but they can actually pick what the areas they're interested in rather than their business as well. And DHEW, not CW, is Digital Healthcare Ecosystem Wales, which is a joint project with Welsh Government and our Life Sciences Hub in Cardiff as well, to sandbox and test some of the projects that are available. So just to give you a flavour, this is what I found. I think there's about 17 different ways that ideas can come in and innovation could come into DHCW, from Welsh Government to our CABs, change advisory boards and other projects as well. So what did I do? So we came up with 3 internal workshops and meetings to try and develop an innovation process map. Part of this was then to create a SharePoint site because we needed somewhere to try and come up with this, and I'm going to show you some examples of the screenshots of what we've developed to support innovation and research in the organisation. As I said, we're also involved earlier in the Bevan Commission processes to share expertise, and there's more liaison now between the exemplars, and they usually have about 40 each year going through as cohorts. Our Assistant Director of IRENE has established a research and innovation working group across the organisation, and from April 2020 I've got with the Patients and Public Assurance Group, which I chair, assures and tests patient-facing digital services. And this is a group of experts and policy leads and engagement leads from all different types of organisations in Wales, supporting from an age, condition, digital inclusion, background, etc. And sensory loss as well. So the proposed process was called IRENE, so you can understand what the letters stand for. We had innovation, research, expertise, need and evaluation. The process actually hasn't worked in that way, but we've actually broken these silos down into different sections, but they still are valid for the area. So there's innovation as an introduction application of those processes and ideas, the research to see whether it actually exists or there are other areas that we can bring in, the expertise, and I'll explain a bit more about that, what do we need and what training requirements are required. Why do we want to do this? The need to gather experience, needs and feasibility, and then testing that for the innovation and sharing the findings. So this is what the screen will look like. It looks like currently on SharePoint, and I should say this also is available for NHS Wales staff as well to use through our NHS Wales legacy for Office 365. So the innovation homepage is broken down into the organisations and boards, database, and what if. So this is the Bright Ideas function on here. We've also linked into the integrated research application system as well. We have a form for the what if. So this is really a place that people can put in any ideas that they have, and it comes through into my email account. But as it's something that's already related to what we're currently doing, and are we happy for this to be shared with the organisation? The other thing we didn't have was a list of all the funding and contacts that we could use. As you can imagine, there's a lot of money out in the UK that we don't really tap into. So I wanted to make sure there was a list available for people to be able to see that. The research form is, again, we wanted to have a template so we could understand how useful that research would be to the organisation. We also have a new services request service within DHCW, so any new ideas as well can come through that format as well. I think there was an interesting comment earlier about expertise, but we're also recognising that we may not have a lot of time to get involved in research and innovation. So it was just a way of breaking down by directorate what the expertise would be offered, whether it be an advice, consultation or more in depth, but also what's available across NHS Wales and industry partners as well, so we can try and tap into that as well. Again, another form, I would really be interested in getting people involved in sharing that expertise. So there was another form that we've developed, and they can limit it to a couple of days a week or for a fixed term, and what skills they want to get out of this, as well as what skills they can give to the organisation. Needs, so sometimes projects commence without a clear idea how DHCW could be involved, or even that people do need our help from the beginning. So one of the ideas was just to have a user needs assessment form available, and whether it linked to national strategies and to our projects as well. Evaluation is about checking, as you can imagine, what you're doing the right thing and in the right way. So we're developing those processes so that there's a process in place. I should say my background, I'm not a clinician, I'm actually a librarian, so as you can imagine, I'm really keen on the evidence base of information. So for many years now, I've been collating what I call a monthly digest of evidence and information. And this is a way of pulling together key resources that are linked to digital technology, which might have an impact on DHCW, and that's available on our SharePoint site as well. We also have other useful links, UK CERP, Life Sciences Hub, etc., and that's what we're building on that at the moment as well. So what's next? Well, the organisation is going to have 2 new executive directors, including a new director of digital strategy. Our medical director is responsible for research, and there are ongoing discussions on research, innovation and education, and a new strategy being developed. I think there are lots of opportunities for us to work with academic research, education and other innovation organisations. And from my perspective, it's promoting the IRENE Hub and keep promoting innovation from my role. Because one of the other areas is that I'm collating an alignment catalogue for our NHS Wales app of resources and projects and apps that we could link in to what we're developing as well from the core service. So that's been really useful, and I've got lots of ideas from today, which I hope we can share back in work as well. Thank you very much for listening, and any questions?
So I said, Joanna's from folks from NHS England here, what are the opportunities to network, share experiences?
I'm a part of the architectural editorial group, which is the Leica SHCRE group as well, so we do feedback there. But yes, I can send you my details, and if you want to get contacts, that'd be brilliant. I'm also always looking for ideas and from people as well, so all across the UK.
And we have another question at the back of the room. We're just moving a microphone around for you guys.
I'm Wendy Deering, and I was in what was then with NHS Wales Informatic Service. Prior to that, I was in Sussex Hills, so I was there at MP Fit times. And I think what a lot we've heard today is around how we should be collaborating. And it was really interesting in the one before lunch in terms of Marcus, in terms of the layering on and what have you, because there's a lot of lessons from both sides of the border. But coming back into Joe mentioned the Wales Institute of Digital Information. I actually formed that and a director, and now I've moved into the university as Dean of the Institute of Management and Health. So coming into Ali's arena, that's how Mark and I got conversations going, because I've just developed and launched the Masters in Digital Skills for Health and Care Professionals, which started last October. So different emphasis from where Ali's coming. Ours are for clinicians, so it's not the Digital Academy, but we were paying lots of money in Wales to go to the Digital Academy because it's devolved nations. And so this one is for our aspiring and those nurses, predominantly because it came on the back of a lessons learnt from implementing the nursing documentation records in Wales, and conversation from there has led us into this master's programme, multi-professional, 60 fully funded places by Welsh Government this year, 60 fully funded places next year, and then sliding scale from there. But actually what we're finding, the learning that's coming out of those first two, even the first two assignments around the systems in Wales, and the good, the bad and the ugly, as somebody mentioned, it's been absolutely amazing. But I think there is lots of work we can do collaboratively, along with the Faculty of Clinical Information's Federation of Informatics Professionals and all the other professional bodies that are coming on stream now to make people working in informatics a profession in its own right. So I think there's a lot of things we can collaborate on, and there's lots of things already being done that we can just perhaps expedite up. Thank you.